Hey guys, I'm Vanessa.
And I'm Sabina.
And today we're going to be presenting on our research project, which is oral lichen planus and HPV.
Our PICO question for this project was, for the management of oral lichen planus in patients that are HPV positive, will the use of corticosteroid therapy as compared to diode laser therapy be more effective in treating oral lesions and decrease the chances of these lesions progressing to oral cancer?
Oral lichen planus is an inflammatory autoimmune disease that often results in painful sores and lesions within the mouth and in the esophageal regions. This disease affects approximately 1 to 4% of the population, and typically it shows up in adult patients that are between the ages of 40 and 60 and also female. Oral lichen planus is twice as more likely to develop in women than in men. What happens is oral lichen planus triggers an immune response that is abnormal, where your own body attacks its mucous cells and destroys the membranes within them that result in open sores and lesions. Human papillomavirus is well known to be a sexually transmitted infection that can occur in someone's oral cavity, in their throat, or also in the genital region. HPV is spread by sexual contact during childbirth from mother to infant, or also in saliva exchange. HPV can be symptomatic or asymptomatic. For the symptomatic lesions that occur with HPV, we see that in skin warts and papilloma growths all over the body, which can also include the mouth, throat, and the neck region. The oral cavity is suspected of being the first entryway of HPV into the body, where the virus will enter in through open cuts or sores or wounds that are in the mouth, and then also in inflamed gum tissue. There is evidence that shows immune cells related to oral lichen planus are the same ones that have been identified in an inflammatory response with HPV, specifically two strains, HPV 16 and HPV 18, which suggests the link that there's a connection between the two. Oral lichen planus is also known to be a precursor to oral cancer, and it is considered to be a premalignant lesion. Studies have shown that the various types of lesions related to oral lichen planus are more susceptible to getting HPV infections. Oral lichen planus most commonly appears in the buccal mucosa, on the tongue, palate, in the gums, and the lower lip, and has also been found in the throat tissue and down the respiratory tract. The lesions that are associated with oral lichen planus are like in those pictures on the top left. They look like a white, lacy patch with small streaks and little white dots. These ones are typically asymptomatic, but in some cases, a lot of them can be painful and have a burning sensation. There are 6 main hallmark appearances of oral lichen planus, called reticular, atrophic, hypertrophic, erosive, bullous, and plaque-like. The most common form of oral lichen planus is reticular, which is the lacy white patch shown in the photographs. The erosive, atrophic, and bullous lesions are known to cause pain and burning, which do require treatment. In rare cases, atrophic oral lichen planus lesions can affect the salivary glands as well. Early detection and diagnosis is important for patients to begin a medication regimen or start laser therapy to treat those painful active lesions and help to reduce the inflammation that is present. Currently, treatment of oral lichen planus is based on managing those symptoms because there is no cure for the disease. One of the most common medications that is prescribed is the use of corticosteroids, which can be applied topically or taken systemically or a combination of both. corticosteroids are known to inhibit the production of specific cells, leukotrienes and prostaglandins, which is what helps bring down that inflammation. Although corticosteroids are commonly used in the management of oral lichen planus, the side effects of them is it suppresses the immune system. So this could be a potential to increase a patient's risk for contracting bacterial and viral infections, specifically HPV. The immune suppression of corticosteroids is believed to be the reason behind high viral loads of HPV found in oral lichen planus biopsies, and why additional research methods and alternative treatment options are needed in the management of oral lichen planus. In most patients, the use of corticosteroids have to become a lifelong regimen in order for them to be effective, and in order for the management of the symptoms to be successful, also relies on the patient being compliant with that daily regimen. It is suggested that the implementation of the diode laser therapy can eliminate the effects commonly associated with long-term use of corticosteroids and be an alternative to long-term treatment option.
Laser treatment is an alternative therapy option in management of oral lesions, specifically in oral lichen planus lesions. Diode laser therapy involves converting electrical energy into light energy, which is absorbed by soft tissues in the oral cavity. One study conducted used diode laser therapy on 60 patients, 30 who presented with OLP lesions and 30 with leukoplakia. After laser therapy was completed, patient healing was monitored at 1, 2, and 4 weeks post-op. The results of the study concluded that 100% of the patients showed signs of healing with minimal scarring by the 4th week and no signs of recurrence in either oral lichen planus lesions or leukoplakia. Post-operative pain was also evaluated at 3 days following the procedure, showing that 90% of patients were pain-free, with 10% reporting negligible pain. We also found another study that also conducted a research on the laser, and similar results were obtained. On this study, the last follow-up was actually done at 6 months, and even at 6 months, 100% of the patients had no signs of recurrence and no signs of scarring, and the tissue healed really well. Although a longer follow-up period is still needed, this theory still shows that the laser therapy would be better than the corticosteroid therapy, as in it doesn't have the side effects that long-term corticosteroid therapy has. Even with these studies, there are still some gaps in the current knowledge, meaning that the etiology of oral lichen planus is still unknown, so more research on that should be done. The process to which oral lichen planus lesions progress to oral cancer is still unknown, and also more studies need to be done on that subject as well. Recently, the relationship and interaction between oral lichen planus and HPV has been studied, but as well there is still need for further research on this subject. Some of the limitations of the existing studies about laser treatment in oral lichen planus are the small numbers of individuals included as subjects and the short post-operative follow-up periods. Further research needs to be conducted to be able to properly demonstrate a cause-effect relationship between oral lichen planus and HPV and their involvement in oral cancer. In conclusion, Oral lichen planus and Oral lichen planus and HPV are two common and important diseases for the dental professional to identify in the oral cavity due to their involvement in the etiology of oral cancer, specifically squamous cell carcinoma. While HPV affects both men and women, OLP lesions are more predominant among the female population. The link between the two diseases, their simultaneous implication in malignant transformations, and long-term effects of current corticosteroid treatment still need to be clarified by further research. Comparing the use of diode laser therapy with corticosteroid therapy in the treatment of OLP patients who also have HPV provides insight into safe alternative therapies for both diseases. The need for minimally invasive treatments that improve oral health, increase quality of life, and decrease chances of malignant transformation for these individuals is supported by finding of recent studies.
That concludes our presentation.
Thank you for watching, and we hope you enjoyed it.